Good afternoon. My name is Brian Chung. I'm the interim CEO of the Hong Kong Genome Institute. Welcome to our Gene Club, the journal club to promote genomic exchange for nurturing talents in the field of genomic medicine. Today, I'm very happy because today's speakers are colleagues of our own. So these are colleagues from the medical and scientific team who are going to talk to you on a very important topic. You remember that we have talked about nephrology, cardiology, ophthalmology, and bone health and mental health. And this time we focus more on children. So this is a very important pediatric topic. And the two speakers, Dr. Ma Wei, our lead scientist, and Ms. Dream Chen, our senior research assistant on genome curation, is going to tell you a very exciting project that needs both genomics and AI to help making genetic diagnosis for children with neurodevelopmental disorders. So without further ado, Dr. Ma Wei and Ms. Dream Chen.
Thank you so much for Dr. Zhong to give me the chance here to represent the whole team, to present you our work on the neurodevelopmental disorders and how genomics and the application of AI technologies help to transform the clinical cares of these patients in Hong Kong. And before we go to the results of our study, I would like to share with you the common patient diagnostic journey that's faced by many of these types of patients in Hong Kong. So for the patients and the families, the genetic disorders we are going to talk about today are actually known as syndromes without a name because these genetic disorders are so rare. And for many patients, they typically born normal, like the patient we'll talk about, born as a healthy baby girl, but her parents, mothers and fathers will soon realize that something's going wrong in this baby because as they grow, she was not developing in the normal speed as other children of the same age. When visiting the health visitors, they will assure that the family that the baby may catch up eventually, but as time passed, it is becoming more clear that something is going very wrong in the patients because at the appropriate age, she was not able to sit up on her own, she was not able to learn how to walk, she was not able to speak Baba and Mama like the other normal children. So it took around a year for the parents and the healthcare providers to really recognize this the situation. And by that time, the developmental delay is very severe. That becomes no longer an overlooked. Okay. Yes. After that, usually a series of genetic tests will be offered to the patients to look for the reasons and cause of the developmental delay. But however, for many of those families, the results will come back negative and the underlying cause remain unknown. And for those families, these non-diagnostic label is very hard to accept because they really need it to explain the conditions to both healthcare providers, schools, social service, and most importantly, they need the diagnosis to help to guide the treatment and the management of the patient. The girl was later joined the Hong Kong Genome Project, and here we help her to find the diagnosis. She was affected by a rare disease called autosomal recessive MPC1-related Niemann-Pick disease type C. This is what we call lipid storage disorder. The gene controls how the fat molecules are being transported in your body cells, and if the gene is not functioning properly, the lipid accumulates in your body and your central nervous system will be affected. And this diagnosis is really important because there is an FDA-approved therapy, Miclifar, that could be used to help to control the disease progression in the patient. And in addition, the diagnosis identified the patient's younger brother who is also at risk to have the same disease and is now already being referred for further genetic testing. And when we talk about neurodevelopmental disorders, we are actually referring to a very heterogeneous groups of disorders. They all refer to children that do not acquire the developmental skill or milestones in the corresponding age compared to the peers. It also includes the autism spectrum disorder that affects the patient's learning, communication, self-care, and social skills. And if these patients cannot recover from the developmental delay, they will be diagnosed at the later age as having intellectual disability. And nowadays, the needs of these patients are being more well recognized by both the public and the government because they really need support in education as well as healthcare to help them to catch up with the development. And especially here highlights the importance of genetics and genomics because for patients affected by genetic neurodevelopmental disorders, they often require more intensive and earlier intervention in order for them to be able to catch up with the normal children. And according to the statistics disclosed by the Trial Assessment Centers in Hong Kong, approximately 3,000 children are newly diagnosed per year to have a significant global developmental delay or autism spectrum disorder. And now steps to Hong Kong Genome Project. We are established by the Hong Kong government with the aim to promote genomic medicine to the local population. And I'm very happy to also remind you or let you know that we have already recruited more than 54,000 cases and completed the sequencing of more than 40,000 genomes. And we covered three major themes: undiagnosed disease, hereditary cancer, and we then expand the scopes to diseases or common diseases that could benefit from genomic medicine, that what we call the genomic and precision health. And neurodevelopmental disorders is one of the cohorts that are taken care under the theme of genomic and precision health. So talking about the current genetic diagnostic guidelines for these patients with global developmental delay, it is actually consists of a battery of different genetic tests. So start with what we call the chromosomal microarray, CMA, on the top left-hand side. So it is used to detect large copy number changes, deletions, and duplications within your genome. And if it comes out negative, we will then consider what we call the karyotype. It is used to detect complex rearrangements in the genome. And besides them, in addition, based on the patient's etiology, there are specific genetic tests that may be offered. For example, for male patients, we may give them a test for Fragile X syndrome. And for female patients with severe intellectual disability, we will give them genetic tests regarding MECP2-related Rett syndrome. And for example, for patients with maybe an increased head size, we will give them targeted sequencing for PTEN, the PTEN gene. And if all these tests comes negative, and then we could proceed to consider next generation sequencing, either in doing it in a gene panel, or we offer whole exome sequencing. However, I'm going to show you in the few couple slides that from the evidence in Hong Kong Genome Project, we actually show that whole genome sequencing can itself as a single test to replace the battery of tests I just mentioned to you. And this is actually with evidence from multiple studies across different nations. In fact, last year in 2025, the American Academy of Pediatrics, based on the existing evidence, now recommends either exome sequencing plus chromosomal microarray or standalone genome sequencing as the first-tier genetic tests for patients with suspected genetic neurodevelopmental disorders because they are shown to have a higher superior diagnostic yield and a higher cost effectiveness when being ordered earlier in the diagnostic process. To be specific, the diagnostic yield of exome sequencing ranged from 28% to around 43% from existing studies. And it is more important that many studies has pointed out genome sequencing offers an even higher diagnostic yield, in average around 10 to 20% higher than exome sequencing. So now I'm going to show you the results we obtained from genome sequencing in a cohort consisting of around 3,072 patients, NDD patients that's being recruited into Hong Kong Genome Project. I'm going to show you how we use the data and results from whole genome sequencing, helping these patients to establish the genetic diagnosis, and subsequently, we use these large amount of data to train AI models to further help to identify patients with a higher risk of being affected by genetic neurodevelopmental disorders. For what we have just mentioned, for all the patients recruited to Hong Kong Genome Project, we provide short-read whole genome sequencing to both the patients as well as the recruited family members. We then applied a customized in-house secondary and tertiary analysis to help them to find the genetic diagnosis. I'm happy to tell you we are able to actually establish 18.6% diagnostic yield in around 570 patients. We help them to establish the genetic diagnosis. And more remarkably, we finished the whole analysis of the 3,000 cases in just 3 months. And talking about the in-house customized pipelines we just mentioned, it consists a comprehensive types of variants that's clinically relevant to neurodevelopmental disorders. It includes starting from the more simple small nucleotide variants to more complex copy number variants and structural variants that affect a larger proportion of the genome. We also include variants such as repeat expansions, as well as other significant changes that's being recorded in literature that's associated with neurodevelopmental disorders. And if we identify any candidate variants, we will proceed to validate them using long-read sequencing if it is necessary. Looking back to the overall diagnostic yield, we are able to identify the diagnosis again in 570 patients, and actually we diagnosed 592 diseases, meaning that there are many patients that's affected by more than one genetic disorders. And apart from the positive diagnosis, we also identify what we call a variant of unknown significance. These are the variants that, based on existing evidence, we still don't 100% sure what's the molecular and clinical effect of those variants. However, many of them are actually upgradable by what we call multi-omics, including RNA sequencing, proteomic profiling, as well as analysis of the DNA methylation pattern. In fact, we have already presented the preliminary results yesterday in an MDT meeting with the Children's Hospital, how we utilize the multi-omics data to upgrade some of the variants to likely pathogenic and confirming the diagnosis. And I hope that we will have a chance to share the results of our multi-omics studies with you, maybe in another talk in the future. And if we consider the diagnosis in the variance level, we identified a total of 618 variants in the all positive diagnosis cases. I'd like to draw your attention to the graph on the left-hand side. For those variant types that's colored in blue, they refer to the variant types that can only be detected by whole genome sequencing. There are around 8% of them, and they are representing really the technically challenging variants that cannot be detected using conventional genetic tests or even exome sequencing. And all these 600 variants spread and distribute evenly across the whole genome. So there are really no what we call hotspots that we may further reduce the size of the genome that we should screen. And among all the positive variants, there is the most frequently recurrent one affects the NAA15 gene. And in the coming slides, I'm going to show you some cases how our genetic diagnosis help to refine the clinical management of these patients with neurodevelopmental disorders. The first one is a 17-year-old male. He was diagnosed with multiple congenital malformations soon after birth. So he has dysmorphic features as well as congenital heart defects. And later, he also developed hearing loss and was diagnosed with global developmental delay. Microarray and whole exome sequencing have been offered to him previously, but the results all came back negative. He was recruited to Hong Kong Genome Project, and here we help him to find the molecular diagnosis. We found a pathogenic variant in the gene PEG3CA. This is a gain-of-function variant, meaning that the variant gives the gene a higher than expected activity. So This is important not only because we help them to establish the diagnosis of PIK3CA-related overgrowth spectrum disorder. This disease, again, has an FDA-approved drug called the alpelisib, which is an inhibitor used to control the increased gene activity being offered by the variant. So this drug, it can be used for both adult and pediatric patients to control the overgrowth as well as the vascular lesions and other functional complications. The other patients I'd like to share is a 1-year-old boy. He's also diagnosed with multiple congenital anomalies. So he also has dysmorphic features, and he also has congenital heart problems affecting the GI tract, as well as metabolic complications. Before recruiting to Hong Kong Genome Project, he received a whole exome sequencing and already identified a pathogenic variant in the GLAD2 gene, confirming the diagnosis of autosomal dominant Kruger-Jones syndrome. The clinical team is very careful because when they examine the correlative phenotypes of the patient with the genetic diagnosis, they found that some of the phenotypes cannot be explained by the GLAD2 variant alone. So the patient was subsequently recruited to us, and we, using whole genome sequencing, identify a technically challenging small deletion in the Franker gene. So you can appreciate from the graph that the exome 11 of the Franker gene is being completely deleted in the patient, confirming the diagnosis of autosomal recessive Fanconi anemia. Plus, with the addition of this diagnosis, now the patient's phenotype can be completely explained by the 2 genetic diagnoses. But more importantly, the identification of Fanconi anemia also has very huge clinical implication because these patients will suffer from very early onset bone marrow failure and will require subsequent bone marrow transplant. For this patient, when he's so young, we can already do HLA typing and identify potential bone marrow donors within the family, so even before the onset of the bone marrow failure. The last patient is a 39-year-old female. She was suffered from severe intellectual disability and epilepsy and remained undiagnosed for a very long time. After she's eventually recruited to HKGP, our WGS helped to identify the genetic diagnosis in the CDKL5 gene, confirming she has a CDKL5 deficiency disorder. And there are a recently approved FDA therapy called ganaxolone, which can be used to control seizures in these types of patients in both pediatric and adult patients. So I hope you appreciate from the 3 cases I presented that the genetic diagnosis for the patients with global developmental delay not only tells them the answer of why they're having the disease, but also hugely impacts the clinical cares and benefit them from the diagnosis. In fact, when we look at our 592 diagnoses, it is very common in 54% of the diagnosis, the results actually impact clinical management. Many of them will have a refined surveillance plan because the genetic diagnosis found that the gene being affected will have other organs abnormalities outside the CNS system. In addition, when we consider medications, in up to 24% of the patients, the genetic diagnosis can be used to help the doctors to choose or refine the therapies that's being given to the patient. And to summarize the findings of the first part of the presentation, I hope you already appreciate that this is actually the current diagnostic workflow for the genetic testings for patients with neurodevelopmental disorders. As we told, it consists of multiple visits to the clinical genetics team and to order a sequential of a battery of different genetic tests for them, and if the results comes negative, they need to revisit the teams again and repeat this process. However, with the refined workflow I just showed you, a single first-tier whole genome sequencing can actually replace the battery of tests above with a higher diagnostic yield and improve the clinical management of the patients. And in addition, this also reduce the burden of the clinical genetic team because now they could focus more to handle the patients with a positive diagnosis. And in the coming part, Ms. Jim Chan will talk more about how we utilize the 3,000 cases to train AI models to further identify patients with higher risk of affected by genetic neurodevelopmental disorders and how this transforms the clinical care pathways of the patients. So Ms. Jim Chan, please.
Thank you very much for Dr. Ma for your great introduction to our developmental disorder cohort and the story and genetic diagnosis result behind this cohort. So after obtaining this genetic diagnosis result from our NDD cohort, we want to further ask an important question, is that can we identify patients who are more likely to receive genetic diagnosis so as to help us better stratify our patient for referral of genetic testing? Through exploring patients' clinical information, there are two approaches for us to address this question. Traditionally, we can manually review literature and gather relevant knowledge from previous experts. Alternatively, with the recent development of artificial intelligence, we can make use of machine learning to help us identify important features automatically. In the upcoming slide, we will present analysis using both the literature-based approach and the machine learning-based approach, and then compare their performance in predicting which patients are more likely to receive a genetic diagnosis. First, using the traditional approach, we gathered 30 key clinical features that have been reported in large reviews. With the use of these features, we perform an association analysis with our NDD cohort data. On the right-hand side of the plot, you can see that features with odds ratio greater than 1, showing that they increase the likelihood of a positive diagnosis, for example, ataxia and hearing loss. While on the left-hand side, there are some features with odds ratio less than 1, indicate that a decrease of likelihood of a diagnosis, for example, autism and speech delay. So actually, we are not just considering one or two features. We would like to see whether we can select a combination of features that can guide us in referring patients for genetic testing. There are several factors we need to take into consideration. First is that this can help us to increase the diagnostic yield. Second, can we maintain a high detection rate and how many cases of positive cases might be missed? So after optimizing these 2 points, we also want to consider the cost effectiveness of genetic testing. As from health economic perspective, this ensures that resources are allocated efficiently while maximize patient benefits. We will make use of some important values to evaluate the performance of different features. First, in precision, also known as positive prediction value, it reflects how accurately a feature predicts true positive cases. Second is recall or call sensitivity, which measures how well the model detects all positive cases across the whole data set. And as we need to balance precision and recall, we also use the F1 score, which calculates their harmonic mean and range from 0 to 1. The higher the F1 score, the better the overall predictive performance. Here, we have simulated around 1 million possible combinations of 20 literature-derived features and applied them to our cohort of 3,000 patients. These cases are shown for the best performance combination, starting from 1 feature and then 2 features and so on. For example, in this bar, showing that there is around a best combination of 5 features, selecting a total of 1,473 patients who have at least one of the 5 features as shown here. Among them, more than 400 positive cases shown in red are included, representing 75% of all diagnoses in our cohort. These are considered as true positive under this selection criteria. Meanwhile, around 1,000 cases shown in blue are patients with negative diagnosis, which are considered as false positive for this selection approach. We can then compute the F1 score for each bar and plot it as this curve. Among different combinations of features, we can see that 8 features showing the highest F1 score in our data, and the 8 features are listed in here. This demonstrates that using this specific set of features providing us the best overall performance for patient selection. So after knowing the result from literature-based approach, let's move on to the application of machine learning. Machine learning can be used to analyze complex patterns and relationships within data. It learns from data and improves with experience. In this study, we follow a structured approach to build our machine learning model. First, we collect, select, and prepare the data. And then the dataset was divided into two parts, one for training and another one for independent validation. And they are using the data from different hospitals to ensure they are performed independently. We train the model using the training dataset and then validate it in the separate dataset to ensure it performs good on unseen data. The model performance was then evaluated using the ROC curve, while the feature importance was interpreted using the sharp analysis. These two methods will be explained more in the later slides. Processing large amounts of clinical information manually can be time-consuming and labor-intensive. So to reduce the time and automate the phenotype interpretation, we make use of the standardized human phenotype ontology term, also called the HPO terms for analysis. Then we develop a HPO term extraction workflow that using large language models. This workflow can extract key clinical features directly from clinical notes and automatically convert them into standardized HPO terms. The output is robust, consistent, and can be generated automatically for the use in model training. However, we found that these HPO terms are not yet directly ready for use as model input. Because HPO terms follow a layered structure to describe patients' phenotype from general features to more specific features. Lower-level HPO terms are more specific, but they may only appear in a small number of patients in our cohort. For example, our cohort has nearly 3,000 distinct HPO terms at the lowest level. These features can be fragmented and noisy, which is not ideal for model training as a direct input. To reduce this noise, we uplift the features to a higher level, grouping similar phenotypes together. This reduces the number of phenotypes as a model input and providing a more robust and optimized dataset for model training. We have applied 4 well-recognized machine learning algorithms in our machine learning training. Each of these algorithms use a different rationale to perform their prediction, allowing us to compare their strengths and evaluate which approach providing the most effective performance in our dataset. To evaluate the model performance, area under curve, also called AUC-ROC, helps us to understand more how the machine learning model works. The curve represents a trade-off between the sensitivity and specificity. An area under curve, as seen here, the larger the area, the better the model in predicting correct prediction. The AUC number range from 0.5 to 1. The larger the number, the better the model performs. In this table of overall model performance, we can see that the random forest algorithm achieved the best AUC-ROC value of around 0.75 during the training. Based on this, we select random forests for the subsequent evaluation. When the model was applied to an independent validation cohort, we also found that the AUC is around 0.7, which is comparable to the training dataset. Finally, we applied the model back to our full cohort of 3,000 patients. The AUC-ROC remains good at 0.8, confirming a good overall performance. We also apply a method called sharp analysis to evaluate the importance of each feature. Sharp is a mathematical framework that calculates how different combinations contribute to the model's output, and then compute the impact of each independent features. This allows us to see how each feature contributes to the model's prediction, making the model more interpretable, and enable us to explain how and why it arrived at its decision. From the result of sharp analysis, we can see that the data point on the right-hand side, shown in red, show that abnormality in mental function, primarily include intellectual disability, is the top features contributing to positive diagnosis in our dataset. Other features such as seizures or abnormalities in hearing or eye movement disorder also play an important role in guiding the models towards a positive diagnosis. On the other hand, there are some features including atypical behavior, which primarily consisting of autism, drive the model to a negative diagnosis. So overall, to compare the performance of literature-selected features versus machine learning, we compare their F1 scores. For the literature-based approach, we calculate the F1 score across all possible combinations of the 20 features and then identify the best performing set among them. In contrast, for the machine learning approach, we consider the complex relationship and interaction across all phenotypes simultaneously and evaluate all possible features combination and captures these multidimensional patterns. Finally, by comparing the F1 score from literature-based knowledge and from machine learning, we can see a clear difference in the performance. Our training model achieved an F1 score at around 0.5, while the best performing combination from literature knowledge is around 0.42. This demonstrates that machine learning provides a stronger predictive performance comparing to human-curated knowledge alone. So manual analysis of HPO term from electronic health records is difficult. Human involvement is prone to error, time-consuming, and can be inconsistent among different practitioners. And practitioners may also follow different practice, which can introduce some bias, making it challenging for standardization. To address this, we developed a standardized approach using HPO term to facilitate the downstream analysis. And with the recent advance of AI has already shown the ability to outperform human analysis. And in the future, they may even achieve a better accuracy. So considering the current workflow of genetic evaluation of NDD patients, each genetic test has its own detection target, cost, and turnaround time. As you can see here, the process can be expensive, slow, and may require multiple rounds of tests. This complexity underscores why a more unified first-tier test like whole genome sequencing could significantly streamline the diagnosis and reduce waiting time for patients. And as you can see here from the data of our cohort, whole genome sequencing as a first-tier test not only can streamline the whole process as compared to conventional tests, it can also capture additional 7% of diagnosis that could be missed by conventional tests. So with the use of WGS, we are able to not just replace a battery of conventional tests, but also can capture additional diagnosis. So here we also perform a simulated model for a health economic analysis. Assume that there are 1,000 patients, they can select WGS as the first-tier test, or they can perform the conventional tests sequentially and using WGS as a last-tier test. By comparing these two approaches, we can see that three major benefits can be seen for the approach of using WGS as first-tier test. First-tier test WGS can provide a 73% reduction of genetic testing costs. It also can provide around 6 months of additional quality-adjusted life years per patient, and more than around 50% shorter time to diagnosis. This underscores both efficiency and the clinical utility of first-tier WGS. To conclude, WGS allows detecting diverse variant types, streamlining the diagnostic pathway for neurodevelopmental disorders. In HKGI, we implement WGS to replace fragmented genetic testing, accelerating the time to diagnosis. At the same time, AI technology enables scalable interpretation of complex phenotypic data, and clinically identifying predictive features support a targeted screening, ensuring that patients more likely to benefit from genetic testing can be referred for further testing. Now we can see that how integrating AI-driven pre-screening with WGS can transform the genetic evaluation pathway for neurodevelopmental disorder. In the current workflow, patients move through clinical geneticists and targeted tests often require multiple rounds of testing if the results are negative. And now we can imagine a new model for genetic evaluation. With the proposed model using AI to identify suitable patients first and apply WGS as first-tier test, positive cases can go directly to clinical geneticists, while negative cases are referred to trial assessment service. This streamlined approach reduces both cost and time, helping patients reaching a genetic diagnosis more efficiently. So this is the end of our sharing, and thank you all for your attention. We would like to especially thank Dr. Zhong for his leadership in this study, and also thank all our colleagues in the Paralleling Center and at HKGI. Thank you very much.
Thank you very much, Dream and Wei, for the excellent presentation. This particular project is really dear to my heart because I'm a pediatrician, and I think all of us agree that children are our future. So we should make the best investment in all of them. And children with neurodevelopmental disorder encompasses multiple conditions that actually require a lot of care and a lot of attention, not only in healthcare, but in the other aspects of their life. I don't know whether you actually feel the same way. This 30 minutes of presentation is actually encompassing multiple, most up-to-date, cutting-edge technologies in healthcare. Of course, this is Hong Kong Genome Project, so genomics is actually taking a central appearance in the whole study. But it's also the application of artificial intelligence. And in order to evaluate the outcome, we also use some techniques in health economics. I think the health economics part is very telling because a lot of us actually have this misconception that if you use technologies, it's going to be more expensive. As a matter of fact, through our very simplistic model of health economics, we actually see a cut in the budget, in the genomic testing cost. It is bringing not only clinical benefits, but benefits in the quality of life of these patients. And importantly, it also solves a lot of headaches for doctors who are working in the clinics as well as working in the laboratory, because by pushing genome sequencing as a first-tier testing, assisted by patient selection using AI, you actually cut down the workload of the very busy laboratories and clinics in different hospitals. So I always have the privileges of asking the first question. I remember this presentation has been done in an earlier version in the University of Hong Kong, and Professor Wai Lau, my mentor, actually said the following. First of all, he liked the part done by Ms. Dream Chen a lot. So his comment, quoted here, is dream is very important. In particular, Ms. Dream Chen is very important. And you can notice from her appearance, she's very young. So as a very young and very talented genome curator, Dream, may I ask you a first question? This is a bit personal. Now, you have learned two things that are quite complex: genomics or genome curation and AI. Which one is more difficult? And do you have some hints to learn these very complicated things? What are the caveats, or what are your tips for other people who are receiving training here to get these techniques more useful in your work?
Thank you, Dr. Zhong, for the question. And I think both genome curation and AI technology can be difficult, but the most important point is just don't afraid to start learning and start searching for the information. So for genome curation, I start here a few years ago, and at the beginning, I don't know even a bit of genome curation, but with the guidance from Dr. Zhong and other seniors, I can learn the details of genome curation gradually, and with experience, I can learn to become a more experienced genome curator. For AI technology, I also just learned to use AI in recent few months, but I think currently we have a lot of resources online or in anywhere we can make use of. So with the brave to use these resources and step forward for each step, I think everyone can achieve this easily.
Thank you so much. So I think to conclude what Dream has said, a mission is very important. When we set out to help a certain group of patients, like patient with neurodevelopmental disorder, this will be our goal. And people would be very important. If you don't have the skills, talk to people who have the expertise and so on. But I think one strength of the Hong Kong Genome Institute is actually we have very good and very strong solutions, technologies, and infrastructure support. So I would like to ask Dr. Ma, what would be the advantages of doing this kind of work in partnership with the Hong Kong Genome Institute with regards to our support in resources like infrastructures and technologies?
Sure, thank you, Dr. I think the question is very good because we are very unique. The Hong Kong Genome Institute, as Dr. has already mentioned, has a very strong infrastructure. I guess, the most obvious one will be the computational resources that you will require because for a single institute, maybe a single hospital, it may not be that flexible for you to acquire maybe server clusters as well as to ensure the GPU resources that you will require technically to build the AI models as well as perform the analysis. So that's point number one. I guess the other point is what we will collaborating with us is what we call an economic of scale because we now have opened the collaboration to all collab research groups within Hong Kong. So now you can expand your cohorts with others and then to maybe group it into a more stronger and larger cohort, which enables you to have the power to identify to expand the analysis. For example, in the GDD cohort, you really need the data from all the 3 partnering hospitals that enable us to both train the data and validate them in independent cases that ensures our model trained is robust enough to be generalized to a larger cohort and other patients unseen in the clinical care system.
So maybe I'll ask one more questions to Dr. Ma. As like any other genetic evaluation, a timely evaluation is so important. Given the scale of the patients that we have in Hong Kong with neurodevelopmental disorders, is there any particular techniques that you have used to make sure that we have a timely delivery of the findings in 3,000 individuals in this cohort?
Yeah, sure. This is very important, I would say, because you really need the scale. What we used here, we call it bespoke cohort analysis. That is, instead of analyzing the patients one by one, we group them. Like in this cohort, they all have a developmental disorder, so we group them and then apply what we call a semi-automated pipeline for the analysis. The semi-auto pipeline consists of a few special features. Number one, it have already automated some of the classification works that we will need to do for every patient. But now, since you don't really need to repeat them one by one, you do them in a cohort, and then you only need to look at the final outputs. That will reduce the time you need to spend per patient. And secondly, because the cohorts is now very focused on neurodevelopmental disorders, we can design specialized and customized bioinformatics and tertiary analysis pipelines to search for certain features. For example, we can automatically prioritize variants that with a higher impact in genes that are known to be associated with neurodevelopmental disorders. And all these types of specially designed analytic approach enable us to further cut down the analysis time. So as we mentioned in this slide, we managed to complete the analysis of this cohort just within 3 months. And again, it's not just replacing whole exome sequencing. It actually replaced many other different types of genetic tests, handling a very broad area and variety of variant types.
This is really a very interesting era because we are really seeing how technologies and new research finding can be directly implemented in the patient care. I noticed that there are a lot of attendants online. If you have questions, please type it in the Q&A part. And now I'm going to open the floor for more questions. And I think Dr. Amy Tong have questions.
Oh, thank you, Dr. Ma and Ms. Chen, for the wonderful talk and very interesting findings. I'm just wondering if you comment on the use of multiomics in applying on rare disease, besides just diagnosis, on other aspects of precision medicine. Thank you.
Thank you for the question. This is another very important question because multiomics is actually our main focus, one of our main focus in the coming year or two. In the area of rare disease, first of all, they are very important because genome sequencing, even whole genome sequencing, focus or it can just detect the variations in the DNA level. In many cases, the DNA evidence is not enough alone. To establish the diagnosis alone, we really need, especially for the variants with uncertain effect, we need data from multiomics to help us to better clarify the functional effect of those variants that eventually help to establish the diagnosis. I've just showed you some cases can be upgraded by RNA sequencing or DNA methylation analysis. In fact, the cases I mentioned that we discussed yesterday with the Children's Hospital, we perform a specific analysis called DNA methylation signature analysis to show that some variants with unknown significance, they actually produce a very signature, very special signature that's unique to the gene. And these signatures can also be observed in patients with a very definitive pathogenic variance in the gene. So we now, for that variance with unknown significance, based on the specific signature it offered, we then upgrade it to likely pathogenic. And the applications, it also holds for RNA sequencing as well as proteomic profiling. And for other diseases besides rare diseases, multiomics is, again, also very important. One focus in Hong Kong Genome Institute is how to apply the genomics and multiomics technology to help patients in cancers. And actually, we have some very exciting works just published in the literature concerning about how multiomics combined with the genomics data help to patients with a very aggressive form of brain tumor, the GBM. And we show that using single-cell sequencing, there's a very cutting-edge sequencing technology that GBM patients actually have very distinguished what we call isoform switchings in the RNA level that could help them maybe to identify or to develop personalized vaccines or personalized cancer treatments in these brain tumor patients.
Thank you, Wei. And I think Dr. Wen-Shu Tang has a question. So Dr. Wen-Shu Tang is actually a multi-omics scientist. Wen-Shu, before you ask your questions, can you spend some time to explain to us our plan of implementing multi-omics in the Hong Kong Genome Project? And then you can ask your question.
Okay, so hello everyone. So we are currently developing, like Dr. Ma has previously mentioned, we are currently developing our multi-omic platform, including RNA-seq and proteomics, as well as DNA methylation signature to help with increase the diagnostic yield. And we are also thinking of how to, when we have a comprehensive data set, how we use the data set to better prioritize the variants using both RNA level and functional level data. And also, we know that RNA-seq is very important in terms of helping to facilitate to find the therapeutic options for patients with rare disease. For example, if we have some splicing variant, we may need RNA-seq to confirm the transcriptome level changes that before we can design the customized personalized therapeutics. So that's what we are currently under development. So you may.
Do you still remember your question?
Okay, so I have two questions. The first question is, the AI model is very impressive. So I'm wondering, how stable are the top features that selected from the model? Have we, if we are trying to use different input, for example, different training sets, do we have similar? Have we got similar features that comes to the top? And the second is the model is very impressive. So can Dr. Ma comment on how we the advantage and how to facilitate the clinical implementation of the AI model?
Okay.
Thank you.
Thank you, thank you. I will the first question regarding on the stability of our model. This is very important. Again, very important questions because the most frequently asked question in AI development is whether the model you trained using the data is generalizable. That means it can be applied to other cohorts. Is it kind of overfit, being focused to the specific training data set we use? For that, we actually answer it by doing extra validation. So that's currently in progress. Besides the data I just shown you that we validated, we trained the data from Children's Hospital and then use the data from Princess Royal Hospital and QMH. And what we are performing is we are gathering cases in the literature, meaning published cases. We have gathered around a few thousand of them and try to see if the model trained using patients from Hong Kong can be applied to patients all over the world. So in those cases reported in the literature, some of the patients eventually receive a genetic diagnosis. Some of them turns out to be negative. And we really hope that our model can show a comparable performance in that external data set. Then that will be a very solid evidence that the data we used to train our model is not biased and our model trained is robust enough to help to predict any patient that we encounter daily in the clinic. So that's so for question number one. The question number two is about the implementation plan. So what our model can achieve is that it is actually an automatic screening model, meaning that if in the future it is possible, it can run every day. Every night after office for the patient clinical records. So they can screen the clinical records automatically, and the next day they will flag up those with a higher risk of having genetic neurodevelopmental disorders to the handling clinicians and remind the clinicians that maybe you should refer the patients to the clinical geneticist team for further evaluation or directly refer them for a first-tier whole genome sequencing test. And then with the test results, then the genetic team can step in to handle those patients in the clinic.
So thank you very much. You see now Dr. Ma actually mentioned another becoming more and more important field of research, digital health. So you can see that when things actually cut into the others discipline, AI, genomics, electronic patient records, health economics, you can really see the most powerful applications when you have these cross-discipline kind of application. Lastly, as a clinician, I want to draw your attention to one of the slides that actually Dr. Ma has mentioned to you. The genetic diagnosis for children with neurodevelopmental disorder is very important. Patients, parents deserve an answer, and these answers, at least in the Hong Kong cohort of over 3,000 individuals that we have shown you, more than 50% leads to improvement in the management. You may think that it is a brain problem, it is genetics, it is irreversible, but studies including the Hong Kong Genome Project has shown that there are more we can do for these children. There are more that we can do for this family if we know the underlying diagnosis. With that, I would like to close today's Gene Club. Stay tuned. We would soon announce the arrangement for the next Gene Club. Thank you very much for your kind attention.